And here there needs huge efforts now with that change in the treatment, that we suddenly get these huge numbers of people tested into the system, into the database. You need something that is really up to that task. And TIA.net is, as I said, something that established itself as a quasi-standard. And so that's going to happen now, so they have really to do something here. And also the next challenge, one of the big challenges regarding data is the identification, because it's mainly not South African, as Hélène Rousseau pointed out. We have a lot of immigration from other South African countries or from other African countries into South Africa, and that produces the challenge that you get a lot of duplicates in here. Okay, so my last point that I want to make here is I want to ask a question, because now obviously I'm in India. I want to ask the question, is there a kind of a BRICS solution where you can have an approach, because currently the whole system is very much driven by South African ideas and American money for the funding for the testing and for the treatment. So it's about 40% of the funding is coming actually now from the US. And we currently face a situation where South Africa can't rely on this anymore. And after hearing all these fantastic contributions today, I asked, isn't there something that we can actually look into a BRICS solution to solve that problem? Thank you very much.
Knowing Africa well, for 4 years I served, very fascinating. It is wonderful what was spoken. We had about the BRICS. There are many such organizations. They have created, but as far as health I know, there is not much has happened in BRICS. There are also Indian Ocean ring countries, etc. There are exchange of certain ideas. They want to create a bank, etc. But so much is not happening as far as the health sector is concerned. So this is wonderful what is being spoken about, different aspects of healthcare innovation. Thank you very much. We'll take the question later. I now request Dr. Satyamurthy, Director of Manipal University.
You at the very outset, let me thank Dr. Angela and Helmut Brand and also Harsh Bharadwaj for giving this opportunity and telling some of correlates of traditional medicine concepts which can potentially be digitalized in future based on the consistent research activity which have been happening in India for the last about a decade or so. Not an expert on traditional medicine, but I happen to learn while doing these kind of research in a setting that was supported by Government of India. And this program which I am referring to is the one which was primarily driven by Professor M.S. Valyathan, Padma Vibhushan Awardee, along with the Department of Research and Science, Dr. Chidambaram's office, who have funded this program, to answer the question of how or what is the basis of traditional medicine effect, which one observes in the individuals, and the knowledge that is available for the researchers or scientists as we speak now. So it is in this regard that I am going to quickly, within 8 minutes, not going into great details, which the queries which I can answer later, and then go through these slides. Now, I am very happy that there has already been a reference to genome and the medicine which is associated, especially from the earlier speaker from Estonia, where wonderful work which has already been initiated and a lot of benefits which has already been reaped by undertaking such kind of references. But at the same time, what has its relation to the population within India and how we can explore or exploit such a knowledge within the Indian population. What is shown here is in general are the complexities which are associated with any given genome of an individual and which can be effectively used to partition people for their phenotypes and diseases, conditions, and so on and so forth. A significant effort has already been undertaken and already been done, and quite a bit of information is available in the databases to indicate that this kind of information can assist, help in digitalization of the information that in fact can predict as well as being able to give appropriate treatment to the people with certain kinds of diseases. So it is in this context, how can we fit traditional knowledge or traditional information into this whole area of expertise? As we know that that the traditional knowledge, especially Ayurveda, is quite nearly 5,000 years old, and it is not alone, although it is one of the oldest. That we also see that there are practices such as Unani, practices such as Satsang and Yin-Yang have already been practiced in other countries such as China, Korea, even in Europe, especially Unani medicine. However, the Ayurveda is basically a way of life. It's not necessarily a treatment, but in fact takes care of the entire aspects of a human being's well-being, which has been studied very well and it has also been explained in many forms. So basically the text which has been written by Charaka and Sushruta and so on and so forth, it is especially for the information of our international guests that man is the epitome of the universe, and within man there is much diversity as much as the world outside. Similarly, the outside world is as diverse as the humans themselves, and in other words, all human beings are living microcosm of the universe, and the universe is a microcosm of the human being. And this is essentially the essence of what Charaka in his text, which has written more than 5,000 years ago, has indicated. So, based on those principles which have been set up, the humans have been classified into 3 broad categories, and there are a few other categories called Vata, Pitta, and Kapha, and these we refer to as Prakritis. And each of these Prakritis are in fact consist of many typical features that are represented by an individual. So a traditionally trained doctor can essentially look at an individual and then tell what kind of a Prakriti he or she is, and then provide a complete health care, not necessarily treatment, but prescribe a way of life for such individuals. And whenever there is a disturbance of these Prakritis, individuals are supposed to get diseases, and these diseases are treated with the traditional medicine, and then these medicines are supposed to revert back into their original Prakritis. There are a number of features under these Prakritis which have been described, and some of which are indicated here. There are approximately about 400 key queries which have been asked to the individual to determine their specific phenotypes, and there are further about 2,000 specific queries are already subcategorized, which belongs to and categorizes individuals into these Prakritis. Now, how can we digitalize these? What are the benefits which one would get by digitalizing these? How can we seamlessly translate this, and how can we seamlessly implement these into the healthcare practices is the question which has been answered based on the genomic basis which has been discovered over the decades, and that can relate and then probably be digitalized through various means. Now, under this program which I have been referring to is that the question was to identify underlying hypotheses and principles of Prakriti classification, but not necessarily discovering treatments or discovering new drugs. And towards this, thousands and thousands of people have been assessed for their Prakritis, and their genomic analysis have been performed, which include looking at mutations and SNPs, epigenetic mechanisms and transcriptomics, and all of this has been done, and it has been established that there are specific signatures which can partition an individual depending on their phenotypes or depending on their Prakritis, and such data is currently available. And again, the individuals are classified based on many of these questions such as this. Although this has been a subjective analysis, but currently the softwares which are already in place, which can specifically determine and correlate with the Prakritis which has been identified, and that can relate and integrate it into the database, and that can be understood. And this is one such example of a very small data which I am going to show you, which encompasses approximately about more than 6,000 individuals, where when we compare the traditional Vaidyas and look at the software and see how much concordance they are, is approximately 80% concordance between how the Vaidyas can predict Prakriti as opposed to software, and there is about 20% discordance in this data. However, that also can be softened out by tweaking out the program in such a way that it complies with the traditional knowledge. And here is yet another example of how these Prakritis information can provide useful information. Just one example, there are about 30 to 40 conditions which can be readily determined based on the Prakritis, but here is an example of an obesity or body mass index which can identify merely by looking at the person's Prakriti and then being able to predict that the person is going to get obesity and associated diseases during subsequent years of life. So there are many other features which have been identified, and for your kind information, all of these are in fact published, available publicly in the literature, and without going into the details because of the short time, the key findings are suggesting that there is a concordance between how subjectively performed Prakriti can correlate with that of the software, how the distribution of Prakriti which we can identify across the population. The manuscript which is published in scientific report primarily brings out these genomic characters and integrates various populations across the world to show that similar concepts and principles can also be integrated into Caucasian population, African population, or Mongolian population, so on and so forth. The association of Prakriti primarily relates to the place of birth, where this provides a major contribution to determine the specific phenotype. As I mentioned, the body mass index, of course, can be predicted by Prakriti. We did not find a relationship between the blood groups and Prakriti. Apparently, it is quite random. And association with the many diseases, for example, arthritis and diabetes and asthma, so on and so forth, and have already been attributed to specific Prakriti phenotypes. And the treatment which has been provided by the traditional Vaidyas or traditional doctors is primarily personalized, because personalized when individuals are classified based on the various Prakritis. So finally, with this slide coming to an end, keeping up with the time, this work has been performed in collaboration not only with the Manipal Academy of Higher Education, but also with the CCME, Hyderabad, and many Ayurvedic institutions from Pune and Udupi have come together. A team of approximately about 400 people have worked for 10 years to be able to evolve this large set of data. Again, it is publicly available, and I acknowledge all their contributions in this way. Thank you, and with this I stop my presentation.
Thank you very much. Wonderful explanation. In fact, now, as you know, we have separate Ministry of Ayush. The Secretary is Ayurveda Acharya from UP, and we have progressed quite a bit of Ayurveda and Yoga. Of course, the Unani, Siddha, and homeopathy was a German concept. Not much has happened. Earlier days, digitalis, quinine, all came from the plants to treat malaria and also heart failure. So phytochemistry has been really a big thing. An Institute of Ayurveda which has come up in Delhi next to Apollo Hospital is doing good work on this. I'm grateful to him that he has brought something very new. I have a very renowned person here, Dr. Shiban Ganju, who is a US citizen, set up a lab in Bangalore, and he has done so much of work. I've heard him about all this, phytochemistry, categorization. Sir, can you raise your hand? So people, yeah. So people can interact with him. A lot of work he has done onto this. And probably this will be good link up that I want to do it for the sake of, because I tell in my magazine people are writing yoga and Ayurveda are Western doctors and not Indian. So I expect this is Indian medicine and we must flourish more in India. Thank you very much. Now I request Mr. Ram for personal health care data.
Good afternoon, ladies and gentlemen. My name is Ram Kiriswarapu. I'm the President, CEO, co-founder and promoter of Take Solutions, a listed company in the National and Bombay Stock Exchanges here in India. Navitas Life Sciences is a wholly owned subsidiary. We're a global clinical research organization. We run several phase 2, phase 3 clinical trials all around the world across several different indications covering oncology, ophthalmology, dermatology, cardiovascular, so on and so forth. And we also run phase 4 interventional and non-interventional studies and real-world evidence-driven studies. And so this session is certainly of great significance. We actually deploy some of these technologies in our own business, so it's very easy for us to present some of the findings and based on our experiences. Thank you so much for giving us the opportunity to be here. Thank you. Quick overview, there are 3 segments to this. There are current challenges, solutions that we would like to talk about a bit, and then conclude with future trends. Now, I'm not going to read out all these things. Through the course of the day, we've heard several speakers talk about these. You heard Robert talk about the spend in the developed nations is not commensurate to what is required. And you also certainly heard everything being summed up with the old adage of saying prevention is better than cure. The challenges are data is available, data is in silos, it's disparate, and it's not telling us the complete story. So in the context of India, what is important is probably what's applicable and what's indigenous. I've also heard some speakers talk about what's practical, what's indigenous, what can be deployed here in this context. So if you look at those data silos, the rising risks and costs, so on and so forth, clearly it calls for global collaboration. And here we are, and we're extremely happy to be a part of this dialogue and looking forward to continuing. I'm now going to invite 2 of my colleagues, Abhishek and Sohu, to present the next set of slides.
Thank you everyone for your time today. So to quickly start off, we've heard a number of solutions here today that can potentially solve some of these challenges that both Ram as well as other presenters, Roberts, for example, the 80% of the childhood rare diseases, some of those issues we have in society, how do we bring together everyone to solve them? So one potential solution here is a health data cooperative, which we'll be learning a little bit more about in some of the later governance sessions as well. But for this health data cooperative, there's typically 3 core elements. Part 1 is your data acquisition, so data acquisition as well as management portion. Part 2 is analytics and insights on top of that. And part 3 is real-world use, applications and consumption. How do people actually use this data out there once we've collected it, and how do we make it a meaningful thing for folks to be able to interact with and use? So we've heard about folks like Dr. Kapoor talking about the app-based innovation, Ms. Rousseau also talking about the applications, for example, the mother and pregnancy applications we have out there. How do we deploy something similar for trying to do a large-scale aggregate analysis, but also keeping everything very safe? One of the underlying themes of the earlier presenters was trust, and being able to do everything in a very transparent manner for folks to be able to relate as well as trust the systems they're using here. For that, now there's a lot of text here, but I'll just quickly give an overview of what we're talking about. With the health data cooperative being the center scope of what we're discussing here today, there's a number of different stakeholders around. We have patients, care providers, policymakers, governments, pharma companies, and of course the insurance providers themselves as well. And as we look at something like a healthcare data cooperative, with the patients, this allows for them to actually have a holistic live documentation and capture of all of their healthcare parameters. That then in turn can lead to healthcare providers themselves to being able to quickly access as well as recommend efficient treatments for these patients. Having all of the data and all the information from a variety of disparate sources, we need something that's source agnostic, format agnostic, that can quickly and effectively bring all this information into one environment so we can leverage that for analysis. Once we have the care providers on board, of course for the policymakers, they can then, with all of this information, proactively intervene. They can collaborate with stakeholders out in the market and address any of the unmet needs that exist. Patient outcomes as a consequence, the competitive landscape in general, all of this helps the pharma companies focus on patient-centered care going forwards. And last but not least, with the insurance companies, this again goes back to the focus of preventative healthcare. All of this greater awareness and greater insight into the data we have, being able to bring the data from multiple different sources together, all of that allows us to quickly and efficiently analyze and draw meaningful conclusions out of all of this. That being said, we are going to do a quick demonstration of 2 solutions we are using. Now, of course, there's many solutions out there for a number of these problems that we're facing. We're going to show, how do we A, collect and aggregate that data, and then B, a quick platform overview for how do we analyze that data and draw meaningful conclusions from there.
you've got a problem. Digital method.
So as that is happening, maybe we just quickly cover this. So basically what we have is, there are a couple of applications, as Abhishek said very clearly, there could be many solutions. One of them clearly is about how do you acquire data. And it's easy. We talked about smartphones and so many applications being available. And the idea is to kind of try and empower patients to try and utilize some of these smartphone-based applications to cover, or to collect data, to schedule their appointments with their care providers, to be able to kind of essentially hold on to, in a very secure manner, the personal health records. Now the key thing is that the next step is obviously to say that if these personal health records are portable, they're managed and maintained securely on a smartphone, are owned by a patient, an individual patient, but as far as caregiving to that patient is concerned, this is fantastic. But how do we then leverage and deploy some of these things for the greater good, right? And the concept that Abhishek was talking about, the healthcare data cooperative. If this information was to be made available, de-identified, and then you start looking at trends, and the kind of stakeholders he talked about in the ecosystem, whether it's the provider communities, the government, the NGOs, the insurance companies, payers, providers, etc. The idea is, are you able to look at some of these trends, disease trends, demographics, profiling by various dimensions? Are you learning something from the data that will allow us to kind of make solid decisions, right? And some of these could go a long way essentially in making sure that care can be provided, patterns and trends can be obviously looked at, insights can be drawn from some of these findings, and the net result is that can we kind of create an ecosystem here where this largeness of data that gets collected can be utilized for effective treatment for the larger humanity or the population itself. So we had two of these applications. Obviously at this point tech has come in our way right now. We don't want to hold up certainly the rest of the proceedings. So maybe we'll just conclude at this point with that. We certainly wanted to showcase this, but post the session, if you do have time, I think we'd love to kind of engage with any of you. Thank you.
Thank you very much. There were two speakers, but they still managed to finish in time. Grateful. We are actually running half an hour late because I want to save some time for the questions and input from people. Now the next panelist is Mr. Joshi. He is from digitalization of Nabi Pariksha.
In my presentation comes up. I also belong to the same section of Dr. presented, which is Ayush Genomics. So I'm not Ayush Genomics, I'm Ayush Nadi. So I'm basically PhD from IIT Bombay. My background is computer science. This all started in 2004. My father was not well and we were not able to find out what the root cause is. And we met someone called Dr. Ashok Bhatt, who was a renowned Nadi Tagya. And he actually felt the Nadi and came up with the root cause. And my dad came out of that cause. So as engineers, my father is also an engineer, I am also an engineer. So it's very hard to believe that these three fingertips can actually find out the root cause of any disorder. So that's how. I started my PhD in the same topic. That let's find out whether there is really science behind it or it's just probability, just history or so on. So the problem which we are currently solving is to find out what is personalized balance and what is personalized imbalance. So sir mentioned about Prakriti. So Prakriti is basically personalized balance when your body, mind, soul, everything is in a balanced state. And when any one of them is in imbalanced state, either genetic, physiological, mental, some disorder occurs. But if you can see, there are so many people, different age groups, different genders, the lady is pregnant, kids, and so on. So for every different dimension, the health is different, the baseline is different. Then how do we really find out? So Ayurveda has Ashtavida Pariksha, 8 methods of diagnosis. So they see, they feel the pulse, they see tongue, eye, mala, mudra, that is stools, urine, touch, voice and posture. So basically how a patient enters the room, how the patient sits in front of me, how he's talking to me, whether the patient starts talking without me asking, or when I ask. So the doctor is continuously observing, making some certain assumptions about the person, about the personality, and then give the personalized touch to the treatment. So I've been working on pulse. We have just started on tongue. We were about to start with eye, but I guess eye is covered already, so I'll skip that. Dr. Kapoor also mentioned that Ayurveda lacks evidence. So yes, it is there. 70% of the people are undergoing Ayurvedic treatment, but there is no documentation, there is no evidence. So can we have a system which produces a report card of any Ayurvedic treatment? A common language is lacking. Suppose a patient goes from one doctor to the other, the languages of two doctors are different. So, the patient cannot convey what this particular doctor said to the other doctor. I'll skip this slide because sir has already covered Vata Pitta. But essentially, Vata is about movements, and Pitta is about energy, Kapha is about structures. Nadi scans the entire body, finds out the root cause, and finds out what should be done to rectify the disorder. So just 3 fingertips, Vata, Pitta, Kapha, and the whole body scan. It's not as easy to digest, but we have started working on this and we see the results. What we are trying to solve is when Tridosha is not balanced, there is some disorder. So how to find the balance, how to find the imbalance, and how to relate that imbalance to some condition. I thought if we were given 15 minutes, so I'll skip few of the slides. But every dosha has properties, every climate has properties, every day has properties, even life has properties, and so on. So in the morning we behave differently, in the evening we behave differently, and so on. That's my journey. As I told you, we started in 2003. I conceptualized in my IIT, came up with 3 sensors. So instead of 3 fingertips, I'm using 3 piezoelectric pressure sensors. So that's the system we came up with. CSIR funded this to actually come up with a prototype, which I got in 2013. My PhD got declined because I worked in Ayurveda, and Ayurveda is not considered as science. But eventually I got in 2012-13. In World Ayurveda Congress, I presented this system just to find whether Ayurvedic Vaidyas need this or not. But they needed some technology. I tried to come up with a wristwatch. Essentially 3 sensors, everyone is going towards variables. But that didn't work out because Nadi shifts along with disorders. It's not always parallel to the wrist. With pregnancy it shifts, with different disorders it shifts, and so on. So this is the system which finally I came up with. In 2015, I got the scientist post in one of the institutes. But I met Dr. Valiathan and he said, just go out of that institute, form a company and launch the product. So I did that. This is the traditional method. This is how I do it. So there are 3 sensors, Vata, Pitta, Kapha, 3 sensors, and which are connected to typical data acquisition system, connected to either a mobile or a laptop. The intelligence algorithms happen there, and a report card comes. So it's a 3-minute procedure in which you have a report card, an Ayurvedic report card in hand. So that's the system, the complete system. That's the method so that the patient gives the hand. All the data is collected in the same way. So standardized data collection, the sensors, data, artificial intelligence, and the report card. So we have a cloud storage where all the data is coming so that as more and more data is coming, the optimization is. I launched the system in March. We have sold more than 200 systems across India. And typically every day we are recording 300 to 400 reports every day. So my intelligence will grow as more and more data is acquired at the server. So I want to show a demo. Can you click the video link, please? Click on me, not on the green button. Click on me. Can you click, please? So as an innovator, I really want to show my innovation. So allow me. Right. So the patient will keep the hand. The doctor will wear the sensors. Will keep the sensors on the wrist where the pulse is available. For 3 sensors, you get 3 waveforms, pulse waveforms acquired at 500 Hz rate. When the data is collected over 2 minutes, all the algorithms run there itself, and you get a report card. I don't know whether the waveforms are visible at the end, but typically they look like this. The colors represent what we curve, and so on. Similar to ECG graph, the pulse signal has PTVD patterns. We are struggling to find out the sources of PTVD. The PQRST is found for last 50 years now. The Nadi patterns are different. For age, for height, for Prakriti, for atmosphere, for calendar, for meals, for thoughts, in different thought processes. After Om Japa, after Pranayama, sir mentioned about Pranayama, after Pranayama Nadi changes, and so on. That's the intelligence happening behind the scene. We are trying to find out what is time series, what is the intervals, similar to heart rate variability, we have pulse rate variability. We are trying to find out the non-linear structures, the descents of the pulse, and so on. The grey line basically indicates the healthy pulse, healthy vata, healthy pitta, healthy kapha, and whether the current pulse is more or less. So whether the vata is in kshay mode or buddhi mode, and so on. And every such parameter, for example, Pala, Agni, Samaga, Sukshmada, so all these Ayurvedic parameters we have extracted by discussing with doctors. So whenever doctor says Bala is less, more, what does Guruta means? Guruta means Vikta Nadi, which has strength, this and that. We try to convert that into computer science language, and we convert into the report card. Some results, I'll skip them, but basically the next we are trying to work on the tongue app. So you just click a selfie of tongue and it will talk about the digestive power, whether we can eat spicy food, whether I can eat pizza or not, and so on. We are working on nose, we are working on face, and so on, and many more things. So Ashtarita Pariksha we saw, basically we are trying to find out in next phase the actual disorders, going beyond Ayurveda. We are concentrating on these 3 disorders. Got some preliminary observations in diabetes, in hypertension. Sure. And that's it. I mean, next era is going to be wearables. So whether a wearable can have personalized touch is what we are working on. So the black box which we are trying to build will have a personalized predictive black box for any wearable. Thank you so much.
Thank you very much. In fact, it's very interesting, but even organizers have told me no more time, so naturally I have to listen to them. It is wonderful what he said. There is some another company done by IIM person, Ayurveda, who is doing some work on the similar concept. He is working on sensors and technology in IIT, and there are also IT people. Very soon, all allopathy doctors, please remember, IIT, IIM, all this will take over. You don't have to be there. They will do all Nadi, Shodha, do everything. It's interesting phase, learning, and really my topic of interest. I now invite the last speaker, Mr. Matthias. He's the founder of IBM Research. IBM is already doing with Manipal on something on a cancer. They are using artificial intelligence. Dr. Partha is the one who is doing it. I will transfer with him in Manipal cancer. Thank you. Yeah.
Thank you very much. Well, the last speaker, and you've been bombarded with a lot of information, so let me take a step back and allow me to reflect a bit on what you've heard. I have been listening to all day, and it's actually quite fascinating how there seems to be a certain universal truth that all speakers, many of you can relate to. One is that we need to have a holistic approach if we really want to change health systems and improve the health of the population. Now, I felt that because I received a PhD in
but I was just working on the technical things, and when I really wanted to have impact on society, I realized, okay, just doing the technical stuff is not enough. So last year I received my PhD in public health. So that kind of nicely complements, in a way, the holistic approach. And I really want to thank Helmut Brandt and Hirsch for organizing this. I hope we have more time for a dialogue, because I'm learning a lot, and I hope you all can learn from all of us a lot too. Now, when I heard I have to present slides, I always start off with like 50, 60 slides, and then I look at, okay, 10 minutes. That's not going to work. So when I finished my slides, it was 14 slides, and then last night, Helmut Brandt told me, maybe cut a few slides, and I listened. I won't show you any slides. So that's evolution and learning right here for you now. How do you translate that, actually? And now I'm putting on my IBM hat. I wanted to tell you the story of Carol McGregor, who was actually the chair in Canada for health informatics. And she walked into the neonatal ICU. You all have seen probably pictures of a baby that is that big,
very good contact for you
full
in this.
room of devices measuring some life. And 10 years ago, the nurse was coming in and writing down the numbers, and nothing happened, and she was thinking, yeah, but what happens with all the data, right? So she actually took that situation, she read all the different signals and analyzed the signals with the help of a platform that we built. Now, that is a small microcosm of holistic approach too. Before it was just every signal on its own, and she actually took the whole picture and analyzed it using technology. And the reason she was doing that was she could predict fungal infections 24 hours, even up to 48 hours in advance. And Carolyn actually, although she lives in Canada, comes from Australia. And as you know, Australia, there are also a few big cities and a lot of rural areas, and here in India you can relate to this, right? If you have a baby in a rural area and you can detect an infection 24 hours in advance, you can do something. You can save that baby's life by actually bringing that baby to a place in the big city where it can be taken care of. That was the motivation, real life saving. But here's another spin-off of this. She was actually using the technology to also reduce the workload of the people working there. You can imagine, like, you've seen those moments where pilots are tested and suddenly the alarm goes off here, the alarm goes off here, and the alarm goes off here. That's the same in the neonatal ICU and an ICU, in fact, where the nurses come rush in and they have to be aware of what's happening. Now that you do this digitally, they see immediately what is actually wrong with this baby. So I guess there's so much more to tell you, but what it's all about, and that's been a thread here too, you have to gather the data, you have to collect the data, and you have to understand the data, and then you have to reason on it, called cognitive computing. And then you learn from it, and you create knowledge, and you learn from it. At the end of the line, there's the human being that learns from it. Yes, artificial intelligence, they're learning systems, true. But in the end, it's the human being that needs to get the insights. It's situational awareness. The computers can make sense of the big data, of the data revolution that is coming. Present the information and data so that the humans can act upon it. And that is, I guess, staying in my 6 minutes, the most important message, that no computer, as said before, is going to replace the human beings. But the technology that's out there, the technology that we also have, it's technology that needs to be filled by your data, by data from India. Not by the apples, but by the guavas, so that you can make sense out of it. And I really hope we have more time for discussions, and I'm happy to share my slides later too. And I thank you all for being here. It's been great visiting Manipal too and seeing how traditional medicine and Western medicine comes together. And if you think about it, that can only happen in places like India, not in the Western world. You have the evidence and the knowledge from the Western world, from the science in the Western world, and you have the wisdom of the traditional medicine here in India. And just imagine if you marry that. That can only happen here in India, and I'm happy that I can help and serve and contribute to it.
Thank you. Thank you very much. So nice of you. A lot of people have spoken about. Okay. Thank you very much. A lot has been talked about data. Data is very good. Developing country in India, problem is reliable data. You can manipulate anything to get the output of your interest, maybe government or anything. And wanted to take some questions, not I, my panelists, but unfortunately they're announcing again and again that your time is up. So I thank my panelists and they are very grateful, they're nice. I've learned a lot, and after one session there's a tea time where these are the people you can talk one-to-one and you can have your meeting. Thank you very much. Now there is some announcement that they want feedback form, which is there. If you are please complete it and give it.
There is a little change in the program. We are starting with the governance model immediately after this session. Is it? We are starting with the governance model immediately after this session. If the speakers are okay with it. And may I invite on stage Robert Madeleine.
To entertain you in between, you will have a presentation that we skipped, and you will see now the one that didn't work until we have fixed all things.
We're going to do a quick demonstration of an application used for the data collection here. So you can see as soon as I go in, I can see my information at the very top of the patient. What do I have to do today? If I click on health over there, you can now see it's verified. Secure platform. So again, the trust element. You can go in there, manage any temporary conditions, any chronic conditions. You can see what your plans are for today in terms of the dashboard. Right as soon as you go into the application, all that information is available right there. You can go into goals tracking. In goals tracking, you can see how long is a temporary or chronic condition supposed to last, any medication plans, any doctor's visits that are associated. Again, this is all the information located in one harmonized environment. Similarly, for chronic conditions, any upcoming doctor recurring schedules for checkups, things of that nature, all of that can be managed right through here. When you continue, you can go into, for example, a patient diary to see on a day-by-day basis what do you have to do. You can add items into that diary. For example, if I'm trying to schedule an appointment with my general practitioner, I can go ahead and schedule that right here. And the nice thing is, again, the comfort for patients, right? So when we create something here, the goal is to have it unified into their existing lifestyle. We don't want them to change. So right when I create this, you'll see directly from my system itself at the very top, you can see a Samsung notification for my actual personal device that now adds this onto my own calendar. So we're not making people change their lifestyles in order to use some of these applications. From there, you can see all of your records can be managed in here. For example, sample medications, prescriptions, EHRs, CAT scans, all of that data can be in here. And then you can share, for example. I'm sharing this information now with Dr. Dipti, who's my GP. You can see you can share it for a certain amount of time or for an extended duration. I can put that information right in there. And then if I go back onto the home screen here, you can see a few other elements of it. Now at the very top, you can see the new appointment that I just added to my calendar is now added up here. I can go into my calendar and see on a day-by-day basis what's coming up in my health future. For example, if I go back to Friday in a second, you'll see that my appointment for my checkup with my GP is up here as well. You can go back onto the home screen, and from here, for example, again, assessments that you want after as a clinician. So you can have any sort of customized assessments in here. This is some lifestyle and wellness assessments we have as a sample, where you can capture all of this information in this environment, whatever the questionnaire is, whatever the assessment is, all that information can then get captured, and then relevant information can of course be provided to patients. We can go into the networking functionality. Again, it's secure, and you have touch verification there. You can, for example, if I click on my friend Sandeep, this can be used simply as a contacts repository. You can see their contact information. Or for someone like Dipti then, if I go into her profile, I can now actually actively manage what was going on with my information. I had granted her access to my prescriptions earlier. I can just as easily as an end user revoke that access as well. So again, the underlying theme of trust here is what we're trying to maintain with the user. From there, for example, external integrations is really where this can go, right? For example, things like Google Fit integrations, Apple Health integrations, 23andMe. Where do we take this forwards? So with that in mind, I'm going to quickly turn it over to my colleague Somu to take this into, once the data is acquired and we have it in the management platform, how do we then run any sort of analysis or any sort of insights off of that?
I'm sorry, I don't have the video to demonstrate the demo, but then I'll go ahead with this slide. So basically, we talked about the data which is being mapped to this mobile app, but then the idea is to convert the data to the information, and we are going to do that basically by integrating the data with a lot of EHR, EMR related information, your lab information, with medical standard information. So the platform which we were about to show earlier, which I don't have the demo now, so that helps you do this integration from different sources, source agnostic. It's not a point-to-point integration, so it may not be very specific to a platform or a technology. And then you can start building insights, and the insights would be at a macro level or a micro level. So the macro level insights are basically for the researchers, or micro level insights for patient care. And these are some of the insights which we wanted to show, but unfortunately I don't have video, but then you can see some of them out here. So that's pretty awesome.
And of course, final future directions, empowering people with their data and improving preventative healthcare is really the final goal. So with that, we'll end here, but thank you so much for the opportunity.
Yeah, welcome. This is a hardcore audience. You're still sitting here to find out how can we make sense out of this house. What kind of model we should use to really get this in. And we have an interesting podium. I will start in the far left. Mr. Srivastava is the former Director General for Health Ministry of Health. Who else as he has the overview about what is possible or not? And because you can summarize it, I would ask you as the last person. In the middle we have Professor Angela Brand. She's working since years on this integration of how can we make use of digitalization of health data, how we can take it, how to put our genome in this, how to put environment in that. I would like you to speak after our first speaker, and you heard him already. And Robert is someone, as you saw by the keynote, who has a helicopter perspective. So he knows, in a way, what is going on in a lot of different countries. Poor, rich, left-wing, conservative, how all those things, like national health service insurance. So what I would like to suggest to you is that we have 3 statements, starting from here, going up to there. But after the statements, then have the first round of discussion, and then come back to further statements from here. So I would now, if this is okay, we'll jump in and ask Robert, well, what is your experience? Because you have dealt with so many different countries, not only in Europe, US, Asia, everywhere. What is this kind of possibility that you see? How can we harness all this digital data floods that coming over? So,
So, very briefly, I think it was good to have had the end of that presentation, because I think what that reminds us of is that if you want to have health data available, you need the data tools, you need the apps. But I think the piece which I would add to that is firstly to recall what I said this morning. You need government and governance, the national vision and the local vision. And then we were talking here about trust being enabled by individuals' control of data use. I believe we have to go one step beyond that, maybe two steps beyond. The first step beyond is community. There are some companies I've worked with a bit in Europe who build the trust not by saying, you, the patient, control your data, but will the patients in a certain group trust their patient organization to decide whether the aggregate data can be used for research? This is very powerful because it builds the community. The second layer of the community is all the patients with the same condition can talk to each other, not just to their families and to their physician. And then the third point, which is a different layer, apart from community, is feedback, as we were saying this morning. And building into these tools the ability for patients' experience, not just for clinical follow-up data, but patient-reported outcome measures to be brought in as well. So community, including community between patients, and reporting and feedback, including aggregated metrics. These are elements which I think will stitch together the data, the tools, and the apps to help to take on. Thank you.
Okay. Angela, with your experience, how can we make this concrete happen what Robert suggested? Any idea?
Might be. But first, I would like to say in my statement there are certain criteria of good governance. And in the context of what we are discussing today, we heard it several times, it's a citizen-owned, controlled data. So citizen and the patients are citizens. Everybody of us, every stakeholder is a citizen, yeah, in the definition. So a citizen can agree or cannot agree to share data. They can opt out, for example. They have a lot of freedom. So that's the first criteria, I would say. The second then would be for good governance and bottom-up approach, truly democratic solution. The third one would be balancing. And I think the personal benefit and the common good. And I think that is the most challenging. And that is something we until now didn't bring together. Either there was personal benefit or the common good. And then to build trust, that was one of the key words in almost all statements today, built on trust and also on legal certainty, I would like to add. Then understanding data as an essential part for health research, healthcare, health improvement, and health systems. And Robert already. Then allowing for both the free flow of data, and then discuss non-personal data, and then the access and reuse of data for future known, but also for future unknown purposes. A lot of questions will come, and we have no clue at the moment what are these purposes. But we have to find a good governance for that. And then the last one may be making best use of the technological innovations, of course, and the health data. So, what did we do? And you mentioned them in the last years. What did we do? We searched internationally for a model of a good governance, which would fulfill all of these criteria of good governance, and globally, which is so it means not only in Europe and specifically under the European presidency. I talked about this morning, but also in Japan, Canada, India, South Africa, etc. So did we find a solution? And we think, yes, we found a solution. And that is that a good governance model indeed putting the citizen proactively in the driver's seat and making the best use of the technologies and the health data for these balanced individual personal benefit and common good. And that, we think, is the cooperative model, the health data or the data cooperating. And because this is a global solution, it's, like I said, bottom-up, it's democratic, it's known to many, many people on the globe. India specifically has a lot of experiences. Think about the banking system, the syndicate bank as a cooperative. Also your supermarkets as a cooperative function. Or you have also in agriculture that's very strong. So that's not new. There's long experience. There's trust in such a model, good governance model. All leadership ask for. So we don't need to invent and think, is that applying to our national systems or state level or community level. So these legal issues are solved, even as a statute for cooperative, international. It complies, that was discussed with Robert, it complies with many existing initiatives. It's very important that it's not replacing, but complementary or inclusive. And it's democratizing the personal data economy and the implemented in existing systems. So again, including existing experiences, existing structures, existing frameworks. All stakeholders will benefit, and maybe we can elaborate on that. So it's not only citizens, it's also industry, it's academia, it is providing for research in the cloud, for example, data, and the policymakers for plans, etc. So what two statements, what we heard from the morning, one is from the opening from Binay Sarjabouda, where he said professionalism with a human touch. I think that's weird to really do it. That's the core. And then there was from the he said, what if doctors, data sharing, what if data sharing would be awarded, and expecting that is an awarding system for everybody who's sharing the data and getting incentives, having the personal data.
Okay, thank you. Mrs. Girasar, the whole day you had to listen to a lot of information. There was no shortage on ideas. And now you had two statements, one global, one concrete. Looking back at your time as Director General for the Health and for Health Services, what do you think? What kind of solutions would be manageable?
There are certain peculiarities with which this country is operating its healthcare system. As per Constitution, health is within the domain of the states. So, majority of things have to be evolved in the state. Our health system naturally is governed by the data which are created previously through systems which were not computer based, now gradually getting up into the system which is largely computer based. India has seen the process of creating health policies normally at a time period of around about 10 years. And the most recent health policy was created in 2017. It has got two major components which I would like to put before you. First is digitalization. So it has demanded from every state that there should be a digital ecosystem created so that we can have a better readdressal of the healthcare problem. And it has also demanded under that digital system application of digital health to telemedicine, innovation and so many things. Besides this thing, India has got another component of healthcare which has been clearly defined in this policy, and that says that we will work out a equity-centric resource allocation. We will try to work out strengthening of the institutional mechanism for consultative decision making. And we will try to have a coordinated implementation mechanism of the various types of targets. It is also demanded that we will link it with the Panchayati Raj system, the system which is operated through our elected members, to do the day-to-day monitoring, supervision, and feedback time. And for this purpose, they have identified horizontal as well as vertical accountability and decided to do increase budgeting for the healthcare, that is from 1.3 or 2, reaching up to 2.5 in an incremental manner, gradually using it. Although they promised for a right-based approach, but looking at the infrastructure available at the country, India decided that we will not have a right-based approach just now, but we will target towards the right-based. But politicized that progressively incremental assurance-based approach with assured funding to create an enabling environment for realizing healthcare as right in the future. Maybe at that time in their mind was that it should match with 2024 SDGs and segment. All these are the top-to-down moving. But the basic data which has to emerge are from the bottom upward. Therefore, it has given liberty to the state to experiment various models. I can share with you one model which I am operating in a state like Rajasthan. The bottom-up approach. It is running about 30 primary health centers and about 100 sub-centers. And it is creating a digital platform, data capturing mechanism, linking with various types of health sector and non-health sector schemes so that it can contribute towards all types of medical as well as social and naturally health determinants which are there. So, the basic message which I want to do, India at present is at a crossroad of linking the technology and the service by increasing investment, probably mixing the top-down as well as bottom-up approach, and the things will gradually unfold in the coming time.
Thank you very much for your statement. And now it's your turn. Let's have the first round of questions that you might have. Up there, 1, 2, and then we look further.
I'm Naresh Gupta from Maulana Azad Medical College, New Delhi. I have a question to the panel which relates to a micro level issue. Whereas I agree in medical science, trust is very important, and so it is being construed for the data. But what I seem to understand is that the ownership of the data is resting with the citizen or the individual or with the patient. Now this ownership, the trust we want to use for using this data for the larger community benefit also has to be safeguarded with legality. So the query that I need clarification on is, if the ownership rests with the individual, in case he decides for the data to be destroyed or removed, what is the take?
Question for you, or for Andhra?
All three.
Who should answer?
Global level, regional level, national level.
Okay. Can we add the second question to this too?
Yeah. I am Jayashree Gupta. I don't know, I can't switch on this mic. Thank you. I am Jayashree Gupta, President Consumers India. So I want to speak from consumers' perspective. Our main problem, one of the main problem is unethical medical practices. The nexus which is there between doctors, pharma companies, diagnostic centers, etc. So is there any app or digital application which could detect these unfair practices? That is number one. And second question is regarding, in India we have huge network of government hospitals, primary health centers, sub-centers, community health centers across India. But their usage is only 70 to 80%. Majority of people are not going there because there is lack of trust and there is huge absenteeism. In the case of Bulandshahr, for example, there were 26 doctors, but the patient was operated by an attendant. So is there a mechanism to monitor what is happening in those remote centers where we always talk about lack of funds, need to strengthen healthcare, but we are paying for 26 doctors' salary?
So first question was what happens when opting out. Second is how to manage unethical practice. Third one is how to monitor use in remote settings.
Thank you.
So if I start with Dr. Gupta's question, I think that the legal framework, start there. I think if India and Europe and some others join hands in saying we have set a similar legal framework, similar principles, we can work together to solve the problem. The second point is ownership. If I buy a truck today, I own the data, but I agree that the company who made the truck can always get it because that will keep the truck on the road. I think we have to conceive personal ownership in a similar way. It's not enough to say it's yours, keep it secret. It's yours, but data is the new blood. Share it not only for your own health, but for others. In the case of withdrawal, I think if it's personalized data, you have to have the right to take away the personalized data file. But there are alternative models where your personalized data is here, and a resiliently depersonalized version is over here in a research database. Now, that doesn't work for all research needs, but it's a feasible way of keeping the big data set as well as personal control. On the Consumers India question, we were talking with some colleagues about this over lunchtime. iwantgreatcare.com is a sort of TripAdvisor where patient-reported outcomes in hospitals with general doctors can be uploaded. Very controversial with health professionals, very useful for hospital managers, and it would deal both with your issue of unethical practices and with your issue of underuse, in my opinion. But you need a quite mature society to roll that out, and even in England it was very controversial, so somebody has to put it out there in the market and create some patient-reported data, which is dirty, it's not pure, but it's usable data, it's actionable data.
Monitoring of the users.
That question, I think it is, so in principle, the questions from outside, from all the stakeholders which might go to this data cooperative can be entered, will be entered. So one of this could be the monitoring question, whether it's monitoring, like I said, of diseases, whether it's post-marketing surveillance, post-drug reactions, whether it's outbreaks, for example, earlier to include syndromic surveillance systems. You can answer almost all these questions with such a data platform. And also you mentioned beyond the healthcare sector, so it's not limited to it. That is, again, that a lot of data will create it not directly also in the health care sector, but also in environment, when I think now about pollution, for example, and these data, or social data, planning data, planning hospitals, planning for answering waiting, etc. So you can, but monitoring definitely is easily be done. It's not very complex, but that is also platform kind of questions and different answers.
Mrs. Leosava, is the are consumer rights strong in India?
Consumer right is very strong in India, but the consumer awareness is not very strong.
Oh, that's interesting. That we can. Good. So, next questions. I think you have one.
I think I need to respond. I need to respond to the question.
Oh, okay.
Because it has got largely Indian response. It needs Indian response. I think the first thing which you have asked about, whether I can opt out if I want. At present, because the system is not organized and not in place, there is no governmental mechanism to address this thing, to opt out. But in most of the time, if a patient wants to opt out of sharing his data, in all the health facilities, this is permissible. Now, in due course of time in the National Health Policy, under the Digital Health Technology and Ecosystem, there is a proposal which is already taking shape to develop a National Digital Health Authority. This authority will take care of e-health, m-health, cloud, internet and all variable. It is also including the artificial intelligence, and it is supposed to regulate, develop and deploy digital health across the continuum of care, wherein this particular question will be definitely addressed to. The second question, which was pertaining to the sub-sectors, shortage and the type of monitoring mechanism. I would like to share with you that the recently launched scheme of Health and Wellness Center, which is going to convert all these sub-centers which are housed there for taking care of 1,000 of population into a technology-driven center or a hybrid type of center, and there is a dedicated fund for it, and there is a linkage with the Panchayati Raj. So the future direction is very clear as far as the national policy is concerned, that the first health post where the patient can get a readdressal of the health of his or her health problem is going to be geared up in due course of time so that it can address to the problem. For this purpose, you must have seen that there are proposals for training different type of health human resource, particularly the different type of alternate system of doctors or nurse practitioners who can be put up over there at 24/7 healthcare provider. So this is to respond to the second question. And I think that is all.
May I ask you, because coming back to the governance issue, you said India is on its way to a health issue. There are signs for this. We saw Modicare launch. You mentioned now again primary healthcare centers that were linked to this. Do I have the right feeling when this is a kind of single payer system where you have a budget outside the government that can be used for health purposes?
The single sentence with the National Health Policy lines that we intend to convert to a single payer system. That writes in that. But it is not that they are going to go for a single payer system, but they say that we intend to go. And the later on announcement, when the National Health Protection Scheme was launched, the later on announcement says, because health is a state subject, so every state will be free to develop either a trust-based or a payer system-based, insurance agency-based type of system over there for meeting the cost, and there will be 60-40 competition.
So competition about the best ideas. We have question here and question then we put at the
Yes, it's actually more of a comment. My name is Richard Bergström. I'm going to be on the next panel, but as I've been in the pharma industry a long time, I can't stay away from the question of unethical behavior. I think the route to take is to create transparency in all the interactions. There are many interactions between private companies and physicians which are absolutely okay, because it's about, particularly if we come with new gadgets and new devices and things and new support tools, you need to tell people about those and how to use them. But there are also unsound practices. In the US there is now legislation, the so-called Sunshine Act, that everything has to be put on the internet. Maybe they went a little bit too far, a cup of coffee has to be disclosed on the internet. In Europe, the industry itself, the pharma industry itself, has implemented a system of full transparency of all financial interactions, contracts, consultancy agreements and so on. And that's, I think, is the way forward. And it goes very well now with the overall building of trust, that you have to have full transparency in all the interactions between the private sector and the healthcare system.
Thank you for the opportunity, and this is Rasmi Mohanty. We are representing here IntraHealth International. So here we would like to add that based on the trust, we have been implementing a mobile health application, M-Sakhi, which is Android-based application, and frontline health workers are empowered. They are using this mobile health application to counsel and save lives, especially newborn lives. So the monitoring, I'm just adding to the monitoring aspect, so it has the real-time data which comes to the dashboard, and we're able to monitor data, real-time data on each indicators and take action. We are tracking and also linking it. We are closely working with government of Uttarakhand. Yeah. Yeah.
Questions regarding to this from the audience, please.
So my name is Uwe Schön. I was on a former panel and I was presenting about the HIV solution. My question is about digital health governance, and I'm addressing now actually my last slide where I mentioned that Tier.net database that they developed in South Africa. And my question around governance is now, I mean, we saw a lot of these applications, databases fail, and I see a lack of standardization. It was kind of a solution that was there and survived, and it's an evolutionary process, it's not a governance process. And my question is, and you see that in a lot of different countries, in Europe with the patient file, the electronic patient file, it was a huge effort to get that in a standard. Institutionalization of that is from my point of view, a governance task. And is there kind of new ideas? We all know how difficult it is, but is there kind of a new idea how to solve these issues, that you don't have a million applications that doing a perfect job, but you